Information exchange between healthcare professionals during the transfer of patient responsibility is a critical communication element. In fact, 2/3 of adverse events in hospitals are related to miscommunication. Formalizing the handoff process provides care personnel the opportunity to exchange, clarify, and confirm patient information, and it also involves patients and their family in the care process. Yet, handoff style, duration, and content are still highly variable in practice, making it challenging to convey consistent content and transmit vital patient information. That's why the Joint Commission calls on healthcare organizations to improve communication among clinical staff by applying targeted tools and solutions. Team Steps, a national initiative to improve quality and efficiency in healthcare, offers such tools. It provides specific handoff tools and strategies to improve information exchange during transition of care, during shift changes, and transfer of responsibility from one team of caregivers to another. The literature on handoff implementation in healthcare is essentially focused on large hospitals and academic medical centers. Little has been reported about handoff implementation and practice in small and rural hospitals. Considering their limited infrastructure and resources, critical access hospitals face pressing challenges in implementing and sustaining quality improvement initiatives. This study contributes to the handoff literature by examining what practices has been developed by critical access hospitals implementing handoffs as part of their Team Steps initiatives, and how implementation attributes relate to handoff performance. This qualitative study is primarily based on two things. One, semi-structured interviews with key informants, and two, structured observations of shift-to-change handoff processes in 8 critical access hospitals in Iowa to identify high-performing and low-performing hospitals. 4 independent coders analyzed the interview transcripts and identified 4 major themes. We then compared qualitative themes in high-performing and low-performing hospitals to examine differences in implementation process, facilitators, barriers, and trajectories. Comparing implementation attributes and hospital performance on handoff indicates that the purpose of implementation did not differ between high and low-performing hospitals, but facilitators and barriers did. Local and institutional factors were the primary significant sub-theme that captured much of the facilitators and barriers identified by key informants. In particular, leadership support and alignment of handoff with the strategic vision of the hospital seemed to be associated with successful implementation and better performance. Staff involvement and being part of the big picture was also an important facilitator to change management and to generate buy-in by explaining the reasons and significance of handoff. The findings from this study provide a guiding framework for small and rural hospitals interested in learning from experiences of other similar hospitals that have implemented handoff. 3 recommendations to hospital leadership. 1. Support and motivate clinical staff to adequately implement handoff process in your hospital by providing adequate resources, time investment, and leadership participation. 2nd, generate buy-in by educating your staff on the evidence, benefits, and reasons for introducing the change and maintaining a positive relationship with all stakeholders. 3rd, develop and apply appropriate measures to identify problems, create solutions, communicate results, and evaluate long-term effects to ensure handoff sustainability.